All right. This case evolved in the following fashion. Actually, before I tell you, because there's some findings on this radiograph that relate to previous surgery, I'll just tell you about that. So the person was admitted for a stroke to our hospital. And this radiograph shows a stent in the aorta, which he had some years ago for treatment of, as far as we know, dissection. And it turns out that he also has a left carotid to subclavian bypass. And then he also had a second operation subsequent to that, involving the thoracoabdominal aorta, which you can't see here, but I'll show you a bit of that. So that's some background. When he came in, he had a stroke, and as is fairly typical, they do both brain and also carotids. So here, one of my colleagues in neuro came in and said, hey, there's something really odd here about the aorta, or I should say the innominate artery particularly. So you see that there. And the lumen is narrowed, and there appears to be some mural abnormality or something definitely wrong with it. Oh, the other thing I should mention is that they also, at the time of the first operation, put in a plug here in the left subclavian artery, so that's that. You can also see here that at this time, the lumen, the opacified lumen of the left carotid is narrow, and there is also extensive opacity in relation to it, and it gets quite narrow and crescentic. And then when we look back at the next CT that he had 4 days prior to that, which I'll bring up alongside, I will show you that he also had some abnormality involving the wall of the innominate artery at that time, but to a lesser extent. So what subsequently followed, and I'll just show you some findings of a stroke that he had, and he also had some findings on some other MRI sequences that were suggestive of emboli elsewhere. So what followed that neck exam was a CT, and here we have our usual routine where we have both the non-contrast and the contrast. So they're actually linked there. So let's have a look. I'm going to try and unlink them for a moment and try to bring out the hyperattenuating crescent of intramural hematoma in the aorta. And it's rather extensive here in the ascending aorta going down to the aortic root. And you can see the extent of opacification of the lumen of the aorta there and the extensive mural abnormality. So he has quite an extensive intramural hematoma involving the aorta, but also involving the innominate artery and the left carotid artery as well. So that was something of a surprise. Just one interesting thing I want to show you is something that we see not infrequently now, perhaps because we pay more attention to this. But here's a location in the aorta just before the stent, where one can see a little intimal breach right here, where there is a communication between the lumen of the aorta and the intramural hematoma just there. So a really interesting case of intramural hematoma, very extensive. And I'm not quite sure exactly what's causing the stroke, but he definitely has that too, of course. And then this finding right there, which is really interesting too. And then I'll just show you really fast here. When I first saw this, I didn't know what was going on. And it turned out that he had a Carrel, C-A-R-R-E-L type patch for the second operation, connecting this portion of the aorta to a whole bunch of visceral arteries like the celiac and a bunch of others from that previous operation. Has anyone seen an IMH so extensively involve innominate artery and other vessels from the aorta, or to the extent that we see here too?
Not to that extent.
There's
No, I
that
agree.
really narrow lumen there, just a little crescent there at that time. So he's been managed conservatively. All right, let me show you another aorta case that's pretty impressive. So here is a person that came in, and let me bring alongside both the axial and the sagittal. Here you'll see this huge pseudoaneurysm arising from the aortic arch. This will give you a feel for where it is in relation to the left subclavian or left carotid here, innominate there. And it's a really wide mouth, big pseudoaneurysm with extensive opacity around it, consistent with blood, presumably blood. And the history here, as you can see from this, is IV drug abuse, diagnosis of a mycotic aneurysm in the setting of staph bacteremia, and you can see the surgery they did for that. So a very impressive and large mycotic aneurysm arising from the top of the aorta there.
Wow, did they do a graft? I can't see the rest of your note there.
Yep, they did a transverse arch replacement and just distal anastomosis between left subclavian and left common carotid. Basically, they replaced the kind of a hemi-arch, partial arch replacement. Yeah, very impressive, huh? Let me show you one nice one that is a complement to the case that Jeff showed last week, if I remember correctly. So here is a chest radiograph, and I'll give you a moment to look at that. Let me bring it up and bring the area of interest to the center, which is down here. So doing that, you can see there is a vessel here. It's rather fat. It seems to come all the way from here and there in that direction. Let me bring alongside it the thick slab I made to show you it. So there it is. And when we trace that big fat guy, pulmonary vein, it goes appropriately to the left atrium. So this is an example of a meandering or a vein, meandering type vein in the spectrum of meandering vein, but it goes appropriately to the left atrium. So it's a pseudo-scimitar. Well, it's not really a scimitar because it hasn't had the scimitar shape, but just an anomalous meandering type pulmonary vein as an incidental finding, but quite a large one. And I think we've shown quite a few of these at this conference, and this is one of the more impressive ones that I've seen. I don't see communications between this one and any others in the form of arcades that we've shown before, but just a nice example of that.
So it's a big fat vein with a funny course, but it only connects to one end. Is that what you're saying? It's not arcuate, meaning it's not connecting in two places?
Yeah, it's just a bunch of veins, and this one is rather fat, and it just goes into the left atrium there, right? There it goes. There it is. Goes into the left atrium properly.
Howard, I'm trying to understand why it's so big. Is it draining a larger?
I don't know.
What's it look like on the lung window settings out in the periphery? If you go to, yeah.
There we go. Let's see if it's doing anything unusual in terms of what it's draining or anything. To my eye, it's not draining anything unusual. It's just, I don't know, it's just a couple of large veins here that join to form the fat one. I don't perceive anything else unusual about it, or anywhere else, or airway abnormality, or does anyone else see anything funny?
There was a second big branch back there.
Yeah, it looks like sort of the dominant vein down there. There's somewhat fewer veins on the right than the left, but it goes all the way out to that pleural surface. Yeah, that big branch.
Yeah,
it's interesting.
You know, there's some other coming in as well.
For whatever reason.
Yeah, just a bunch of other veins coming in there, but this big fat guy there. So no particular reason that I can see. Just a fairly impressive big thing. Okay, I have some others, but why don't you go and let other folks show, and then I can show more if you want me to.
All right, we'll go to Travis now. He's back.
All right, do you see my screen?
Yes, we do.
Yep.
Okay, 87-year-old woman. This was a case from a couple months ago that I've wanted to show. She came in with hematemesis and some chest and abdominal pain and had this CT done. You can see she's got a pacer and otherwise not really, you know, not doing too bad for 87 years old. And the finding you see here is her esophagus. And we see that there's this eccentric soft tissue that extends really from the thoracic inlet, looks a little weird up top, and then all the way really towards her gastroesophageal junction. And now we didn't have any history at this time, and we're thinking, you know, maybe this is some weird, large, like elongated mass. It'd be awfully unusual. There are a couple small lymph nodes adjacent to it. That was the first thing that we were thinking, and then, you know, could she just have retained debris or something in the esophagus? We thought that was less likely. There was one thing we didn't think of, though, to include in the differential, which is, it's a good thing they decided to repeat with an esophagram before they scoped her. Apparently, more history after evaluation with the GI team is she had had a normal EGD within the last few months. So they thought the chance of this being some sort of cancer was pretty unlikely. And so as part of the esophagram the next day, they did a non-contrast study. And this nicely shows that it's very high attenuation on the non-contrast. And so this is all just a submucosal hematoma, presumably just from retching. And we don't know where the bleed was. I think she may have been anticoagulated and super therapeutic, but not a mass, and something that we don't see that often. And usually the cases I've seen have been in the setting of intervention, like a nasogastric tube that ends up dissecting in the submucosal layer. But important thing not to forget, I guess, on differential for longer segment abnormalities of the esophagus. And so, of course, she was treated conservatively.
So Travis, I had a cool case of an esophageal duplication cyst that hemorrhaged, and then the blood dissected all up and down the submucosa of the esophagus. I showed that a couple of years ago. They called it an esophageal intramural hematoma.
Yeah.
Anyways, but that extended from stem to stern, all the hemorrhage from anyways.
Yeah, no, I'll have to look that one up, or maybe you can pull it up and show it again, because the only cases I've seen were, the only cases I've seen were from some sort of tube that dissected in the wall or created trauma like this. But this was just presumably from hematemesis.
Travis, I showed a case a while ago of what looked like I think we called it an esophageal dissection, where there was gas tracking in the wall. That I kind of was reminiscent of that image right there on your left, screen left, where you see that little eccentric gas collection.
Yes.
It doesn't quite look luminal.
Right. Yeah, no, we kind of
get a micro.
We went down the tube forgetting about that. I think we were all too fixed on cancer, but
I thought this was one of those fibrovascular polyps, those enormous long things that people sometimes cough out that looks like a gym socks with their gym clothes.
Right, that can sometimes have like macroscopic fat and things in it.
Mm-hmm.
Yeah, no. So, I mean, that was one of the things we were thinking on the differential, in terms of a mass. I mean, even like lymphoma or something submucosal or just a really long leiomyoma, but this was just hematoma. Now, this next case is a nice one from the VA. And I'll start with a series of radiographs. This is a 64-year-old man, and this radiograph, as you can see, is from 2010. He's got a couple of calcified granulomas in the left lung and the left hilum, maybe a little bit of linear scar, and then additionally some consolidation in his left lower lobe. And I'll show that next to this radiograph here in 2017 now. And now you can see that he has this stuff in the left lower lobe is resolved, but he has complete left upper lobe atelectasis, a little bit of a lift here. I think this is also cool that he has this shifting granuloma sign from the volume loss, that this cephalad, again, indicative of the volume loss on that side. And so, of course, the possibility of cancer. He's an outpatient with an presumably an obstructing endobronchial lesion was raised, and so they went to CT. The one thing I'll point you to is the calcification that's in the left hilum from this granulomatous disease. And when you see the CT, everybody probably knows what they're going to see here, but there's a huge broncholith obstructing his left upper lobe bronchus. And this was one that this was interpreted as, you know, an obstructing lesion, worrisome for cancer, and went to PET. And it was after the PET, because the PET was hot, and I'll show you, I think I have the PET I can show you here, which of course was also, you know, they said there was hypermetabolism there and thought it might be cancer, but when we reviewed it before tumor board, you can see it's pretty hot right there. But we felt it was most likely a bronchiolith. He actually underwent a left upper lobectomy because he was having some hemoptysis, and it was just a bronchiolith. There was no tumor there. And this was just some post-obstructive pneumonia in his left upper lobe. So a nice example just of evolution. And I think even on this original radiograph, you can see there's probably some volume loss already in that left upper lobe. You know, it looks like there's fewer vessels there, a little bit of elevation of that diaphragm. And I don't know what this left lower lobe stuff was, if it was aspiration or just an unrelated pneumonia. But a nice non-cancerous cause of left upper lobe collapse.
Or maybe he was getting some hemorrhage or
Sure.
down there.
That's true too, yeah. He could have, I don't know the history back then. Let me show one more for now. This is one I just saw that came into our ILD clinic last week. And this is the patient's radiograph, and this is a 17-year-old, so pretty young. And his story was, this was in June, his story was last December in 2016. He had some viral upper respiratory illness, and then over the course of the spring got progressively more and more dyspneic. And by the time he presented to the outside hospital, was unable to walk more than 40 feet when they did a walk test, and he was satting in the 80s on room air. And I think, to me, the first thing I thought when I saw this radiograph is he's got bilateral, somewhat peripheral and symmetric areas of consolidation. And, you know, given his protracted course, I was thinking originally that this is maybe going to be organizing pneumonia based on this look. I think what's interesting on the lateral view, and I know Howard likes to talk about this a lot, is just how thick the fissures are. And this is, yeah, it's, you know, it's like subpleural edema, it looks like here on this radiograph. And then the CT is quite interesting, is that he has some more, it's more centrilobular nodules and ground glass opacities and nodular areas of consolidation intermixed with a lot of bronchial wall thickening. You can see these clustered centrilobular nodules. He's got a lot of lymphadenopathy in his mediastinum, which you can see here. And then he's got small effusions. And so anybody want to take a shot at what the ultimate diagnosis is here?
He's not shooting up drugs or anything like that, ground up tablets.
Nope. No, he's straight and narrow.
Is it PVOD?
It is PVOD. Yeah, they ended up doing a right heart cath. His mean pulmonary artery pressure was in the 30s, but it wasn't just PVOD. They went to lung biopsy, and they did a surgical lung biopsy, and you'll see that it was, he also had this granulomatous angiitis with associated PVOD and, of course, pulmonary capillary hemangiomatosis, since I think we all think that these are probably part of the same spectrum. And he has this organizing alveolar hemorrhage and organizing pneumonia, which I think the hemorrhage and organizing pneumonia accounts for some of the ground glass and consolidation, especially the hemorrhage. One of the reasons I love our pathologist is he gives these long lengthy descriptions on these findings, and it admits that this is a really unusual case where he thinks the inciting event is this granulomatous angeitis, so just granulomatous inflammation of the small vessels, resulting in a pulmonary veno-occlusive disease. And then I can let you read through these, but basically the conclusion is he finds a couple of case reports with similar findings, and I've included one of them in here. So it's really an interesting case. So I don't know if anybody else has seen this type of constellation of findings. But really, if you subtract out some of the central lobular stuff, the rest of it's great for PVOD. And of course, yeah, we see central lobular nodules too with the capillary hemangiomatosis and PVOD as well. But I think this is more of that hemorrhage that they see here. So,
the granulomatous is the path. The granulomatous angeitis is the pathfinding when people shoot up tablets and get a vasculopathy from that. There was just a case report of what we call excipient lung, but it was attributed to injection, I think, of heroin. So maybe the talc that was used to cut the heroin in a New England Journal in the last few weeks. And it showed these very nice central lobular nodules.
Yeah, and that was actually a case from Emory. And I think it was one of the ones that I diagnosed, and they didn't include any of us in that case report. But that's beside the point. But yeah, no, this guy did not inject, and he did not inject. There was no polarizable material. But it's just, and it's, yeah, it's really an interesting case. So, but path proven PVOD.
Travis, could you see the pulmonary hypertension on the CT scan?
Good question. And the answer is maybe. I mean, he's a small guy. His pulmonary artery is going to be larger than his aorta, probably. Let's see. Yeah, 29 versus 25 or 26. So the ratio is greater than 1 to 1. And then looking at his peripheral pulmonary arteries, they are bigger, more dilated than the accompanying vessels, even though he's got a lot of this, the peribronchial cuffing. So
does the pathology report describe a granulomatous venulitis in particular rather than, say, a granulomatous arteritis? I'm just curious.
Oh, let's see. I think it's more just the veins are obliterated. Let's see. Oh, no, you're right. Granuloma is obliterating the veins, the intermediate-sized pulmonary veins, too. Yes. Yes.
Very interesting.
And there was a reference that you had somewhere there that said granulomatous venulitis and PVOD somewhere. I don't think I've seen it before.
So this is, I've included one of these. Yeah, this is an older one. I actually included this paper here, the European Respiratory Journal case report.
Yeah,
and
that
was
one
where,
Wow, that's so interesting. So this is an idiopathic granulomatous venulitis, huh?
Yeah,
wow.
And I mean, I guess, yeah, and as most of these cases of PVOD that we see are idiopathic, in general. So.
Yeah. That is
all right. I will hand off to there, Jeff.
All right. Seth, David.
I got a couple.
Okay.
So can people see a chest röntgenogram here with right lower lobe consolidation?
I can.
Okay, so this person came in with shortness of breath and coughing up, choking on mucus plugs and things like that. Described coughing up things that reminded her of the Harry Potter scene where his friend Rob evidently is coughing up slugs because I guess he got enchanted. He was practicing with his wand or something like that and accidentally hexed himself and was coughing up slippery slugs. So this person described that sort of thing and had this chest radiograph. I thought that this was a classic aspiration. And let me see if I can. Here's a later radiograph, and this is after a lymph angiogram was done in this person. At this point, there's somewhat less consolidation in the right lower lobe, but there's right pleural effusion. And let me show you a CT scan on this person. The initial CT scan shows some material here in the airways. At this point, the lower lobe consolidation isn't as apparent as it was before. We got some stuff in middle lobe. And the person did have a lymph angiogram, which was considered grossly abnormal with lots of proliferation of these and distension of these thoracic lymphatics. Let me look farther down here. I think there are some scenes from the lower part. So very grossly abnormal lymph angiogram here with a lot of lymphangiographic contrast getting out here into the right lung. And so I was concerned on the CT scan that this person had a lot of mediastinal lymphadenopathy because there's all of this fuzzy stuff throughout the mediastinum. I thought this was a case of lymphoma, that there was lymphatic involvement, and that this person with a diagnosis, a clinical diagnosis of plastic bronchitis, had a plastic bronchitis secondary to lymphoma with obstruction of lymphatics. You can see that there are some structures back here that could be lymphadenopathy going down into the abdomen, but these could also be lymphatics, these retromediastinal structures here in the paraspinal location. So I thought this was going to be lymphoma. There were biopsies and there was no lymphadenopathy here. There was nothing wrong on their node sampling. So this is not lymphoma. And this ultimately is considered an idiopathic plastic bronchitis. There was an attempt to do some embolization of her lymphatics to keep the lymph material from getting into her lungs and then forming these slippery plugs that she coughed. But that was unsuccessful. They tried to locate the cisterna chyli and then put a needle into it, but they could never see a well-formed cisterna chyli to do this. She went to another hospital, or she was headed to another hospital to get another procedure where they might be successful. This is one of her last radiographs, and you can see her lung disease had partly cleared. The effect of the lymph angiogram is sometimes to cause enough sclerosis that the lymphatics would shrink down and she wouldn't have all of this lymph fluid going into her lungs and forming these plugs. So the bronchoscopic findings in this person were pretty dramatic. So this is a huge slippery white mucus plug that was kind of oozing out of her airway. Here is another view of this thing, sort of along this thing. She had the sensation of choking on these things. She didn't find this a pleasant experience. And here's one of these, yellowish things removed here. Another view of these mucus plugs. So she would just keep coughing these things out several per day. She was somewhat better after the lymph angiogram. So plastic bronchitis here.
That's pretty cool.
Yeah.
Yeah, David, I came across a case report, I don't remember how old it was, of a kid who had lymphangiectasia who got better after diagnostic lymph angiography, and the thought was the thiodol caused some kind of lymphosclerosis, like you alluded to.
Yeah, I think that's what they were hoping for here, and maybe she did get some treatment effect from it, but the definitive procedure was not done. They were going to do some coiling, but they never got in. Maybe she will have success at an outside institution. Okay.
So, David, is there chylous material in those plugs, or what are they made of? Is it just mucus?
It's proteinaceous. It's proteinaceous stuff. I don't know what the chemical composition is, and I don't know whether it was analyzed. I should go back and see if there was any analysis done on these things. They may have just ended up in the trash can. Okay, so let's see. Here is another person who has a port catheter. Let me see. Let me show you what happened subsequently to this person. Okay, so this is an initial radiograph on this person from 2016, showing a normal position of the right hemidiaphragm. This person has hepatocellular carcinoma, has a port catheter in place. Because of that, has this little marker here in the liver. Coronal imaging on this person, and this is March of 2017. And this is after some therapy for hepatocellular carcinoma. They did some angiographic procedure. I think they froze or heated some lesions there at the dome of the liver. And what we're having here is actually an effect on the diaphragm. So initially, after the procedure, the diaphragm had a normal contour. At this point, we have this little blip here that seems to have a separate arc from the rest of the diaphragm. And things got worse. So here is 9/17. This is 6 months later. And you can see that there's now a lot more liver that is herniated through a defect here that was caused by the procedures done to this for this hepatocellular carcinoma. So I don't know whether they heated it or cooled it or something, but they did damage diaphragm, and there was at this point a hernia. I'll show it to you on sagittal view, because I know you don't believe me. So we got this big mushroom here of liver like this above this defect posteriorly here. So this was a diaphragm hernia caused by treatment of hepatocellular carcinoma. And so she had a patch placed to cover this defect. And after that, this is post-op now. At this point, we have a big pleural effusion that's obscuring the diaphragm, so I don't really know what sort of contour the diaphragm has. We'll have to wait for a later post-operative imaging here to see if the diaphragm is looking more intact than before. So a complication here of treated hepatocellular carcinoma. Okay, and this person had lung transplant, and keep your eye on these sternotomy wires, these transverse sternotomy wires at this point. At this point, the lung volume was a bit low, but the lungs are pretty clear, just a little bit of basal atelectasis. And then later on, we have this radiograph, and at this point, notice that the sternotomy wires have fragmented, and there are actually some missing portions here, but we can find the missing portion out here in the right lower lobe. So these sternotomy wires here have broken, and I believe one of them poked into the right ventricle, or yeah, at this level, probably right ventricle, not pulmonary artery, and then embolized to lung. So we should be able to find it here on CT. And here's our wire out here, sitting out here. So an embolized wire fragment here from fractured sternotomy wires, I think probably directly inoculated into right ventricle nearby, and then embolized to right lung. So,
or how about just motion and breathing, making the wire just traverse the mediastinal fat into the lung rather than getting there via the bloodstream? Is that possible? Just a sharp thing?
Yeah, what's so far? It seems awfully remote for that.
Well, you can trace it from a vessel, can't you?
Right. So here's the vessel. Let's just keep following that vessel. I think it's vessel. Yeah. Just by it's continuing the course of a precursor vessel that's moving right toward it. So I would go with embolization here.
I see.
Yeah, and it looks like a little arteriole. There's a bronchus more centrally next to it. That's interesting. Now, David, what was the time frame after clamshell sternotomy? Years?
Well, there was. I was wondering whether there was another procedure here, but this happened between 2016 and 2017. So let me go back to the. Let's see. I guess the original radiograph here maybe a different set. Let me pull it up. Yeah, this is 2016. At this point, you can see that I think the wire is broken already.
Yeah.
You know, these are very precarious fixations here of the sternum. With a normal median sternotomy, you've got a big surface area that you're opposing. You've got several wires doing it. These transverse things, you're basically trying to perch this little piece of bone on top of another little piece of bone, and there's a lot of movement of the sternum, and you just don't have a very secure fixation. And broken wires are pretty common. I don't know whether
that sternal offset is pretty typical for all of our lung transplants. We were having this discussion the other day too. Usually they're not.
Yeah, we see those here too.
David, I showed a case, at least I hope I showed it, but I have a case that I think I showed about 4 or 5 years ago where we had one of these break and it was lodged in the right ventricle. So that seems like a good place for him to go.
Wow.
Okay, those are my cases.
All righty.
Impressive.
Seth?
Yeah, I can show mine real quick. Share mine. Okay, so real quick, this is something I'd not seen before. Maybe you guys have seen it. This is just I'll send the real image. So I called this morning about this arterially placed subclavian catheter, saying you guys put it in the wrong place. But it actually turns out that this is a subclavian approach intra-aortic balloon pump. I had never seen one. I didn't know they made those. I don't see the balloon pump. They told me it's well below, it's down in the belly. But I also asked them very nicely if they're going to put these in the future to please let us know that that's what it is versus a attempted venous line. But it does have a little bit of a different look than most standard subclavian catheters. But I don't know if anyone else has ever seen one. I have not.
We have a current case of this, and I've seen a few before. And the problem with it is the marker, which is the proximal end of the balloon, was above the aortic arch. And so in the normal situation, you say you need to pull this balloon down, because if the balloon went into the line, you're talking about the top end of the balloon, and you don't want it going up in a carotid or a subclavian artery. But in this one, it was above the aortic arch. But in order to change that, to make that better, they would have to push it in. And they don't want to push in catheters because they take infection in with them. So it's easier to pull a catheter out. That's safe, but it's a septic problem if you try to push a catheter in. So they've never been able to adjust it. And the marker is sitting just at the top edge of the aortic arch. And previously, before a couple of days ago, was actually floating about a centimeter above. And we could see the bottom marker in that case in the upper abdomen.
So I looked, I couldn't see either marker, but they're like, oh, it's there, don't worry. I'm like, okay.
Okay, I'll load up my case for next week. I'll pull it up.
Yeah. So that was one. And then here, Travis, is that case real quick from one of my, switch this real quick, lecture showing this, this was an esophageal duplication cyst. And then patient came back a few months later with severe chest pain, and it hemorrhaged, and the hemorrhage extended all up and down the entire esophagus. So,
wow.
Anyways, so I'll try to find the DICOMs for that and send it along. And then this is an interesting case that I know Travis showed a really nice case of this, very similar a few months ago. But let me lower this because this is in my way. But this is a guy, really fast. He's talking. Here's a guy with tracheomalacia, just doing a nice temporary resolution CT, just multiple axial images showing the complete collapse of the trachea there. And then interestingly, just a nice example of the difference between tracheal malacia and bronchomalacia. Oh, this is not the image, but he does. No, here. So he actually also had in addition to tracheomalacia and bronchomalacia, he also had a fixed stenosis sitting right in here. So I'll send over the whole data set, but that's just a nice case of tracheobronchomalacia on kind of a perfusion temporal resolution scan. This was a cool case that I went down the tubes on a few months. The first scan, this one I caught it on. So here was a woman with diagnosis as metastatic breast cancer. She's got bone mets. She's got some nodal mets. And when I read the study last time before this, she has all these scattered pulmonary nodules all over the place. Also noticed is the nice mosaic attenuation, which was more conspicuous on the current scan, because I think she was at some degree of, well, no, it actually was the same. I'm not going to lie. I just assumed this breast cancer was mets. Anyways, this time I was like, God, it kind of looks like dip neck. Went back to older studies. Sure enough, these nodules were there, but much smaller. But this was many, many years ago, and even going back into 2007. And so sure enough that looking at her history, she did undergo wedge resection of multiple of these lesions, and they were carcinoid tumors, and she also had multiple carcinoid tumorlets. And she has a long-standing history of quote-unquote asthma. So this is a case where in the scan before this, I called it Mets unchanged, but in reality, it was dip neck. So a nice kind of case of that.
I've done that with
I mean, it's just.
I've done that with sarcoid and metastatic breast cancer. Confuse those two.
Yeah, I mean, it was just one of these things, you're tearing through cases, it's a long day, and you got, you're like, oh yeah, mosaic attenuation, small airways disease, and then multiple pulmonary nodules, metastatic disease unchanged. And then you just got to take more time than that and really kind of absorb the case. And when I finally did that, came the right diagnosis. But again, we've been imaging this woman for years and been calling it stable metastasis, unfortunately. But the clinicians know because they have path. And this is a case, this is just a quick case, but a very nice example of young male HIV, Kaposi's sarcoma virus, and actually Kaposi's sarcoma on the skin. I don't see any evidence of that here. I mean, there's some areas of thickening, but anyways, very avidly enhancing lymph nodes, large spleen. So this is just a very, very nice case of multicentric Castleman disease with these avidly enhancing nodes throughout the chest and also abdomen and pelvis. And then for a kicker, not because this is anything chest related, but I came across this the other day, and this was just the largest scrotal hernia I've ever seen, and figured I'd throw that in for fun. So there you guys go. I mean, it's below the knees. It's pretty impressive. Contains most of his abdominal cavity.
Wasn't ready for that one.
I forgot.
This guy would get the locker room award. Nobody could compete.
Yeah, I just saw that. I'm like, okay, for some humor, I feel bad for the guy, but nonetheless, that's pretty impressive. But anyways, okay, Jeff, those are my cases very quickly. I'll let you finish up.
Yeah. Okay, let's see. So, David, your timing could not be more perfect. So let's see. You guys should be seeing a CT scan. So this is that case I had sent around earlier of this 30-some-odd-year-old guy who back in February developed, quote, pneumonia, didn't get better, was found to have IgG deficiency. Here's his initial CT scan. And this has been our exciting case of the week around here as we've gotten some more information. So this was his CT when he presented, and you can see he's got this subpleural sort of not quite septal lines, but you can see these thickening right where the interlobular septa would plug into the pleura. And he's got irregularity along the fissure and the veins and the bronchovascular bundles. And then he's got this very interesting pattern. It's sort of, I would almost call them acinar type nodules to invoke an older term, but it's almost the whole lobules involved, but they're sparing on the periphery. So there's a lobular filling process with a little bit of septal thickening. So that was February. He was treated with multiple rounds of antibiotics, didn't get better, got a bronchoscopy somewhere else. No one really was going on. So here he was in June, looks pretty much the same. And then 5 days later, he gets another CT, and you can see it got a lot better. And we didn't know at the time what had happened. We looked at IgG replacement therapy. We looked at drugs, hemorrhage, edema. Well, he got a bronchoscopy last week, and he also got some more workup done. And let's see if I can find the bronch images. Yes. So this is the bronch, and you can see he's got this white liquid all throughout the airways. And it's kind of got this nodularity. And this is all the fluid that came from the BAL. Because he was sent to us with a diagnosis of alveolar proteinosis, which I didn't like, and I don't think any of us liked. And when I shared it with some of you, you guys had agreed that it didn't look like alveolar proteinosis, and it shouldn't clear up like that.
Up there, right? So it's like the exact opposite.
All right. So, and then he got CT'd again back in September, and you can see it recurred in exactly the same place. A couple other imaging findings to share. Let's see on this coronal. Is you can see there's some what looks like lymph node enlargement in the mediastinum, and I want to find the transaxial ones here. Here we go. And we can see there is all this what looks like lymph node enlargement in the mediastinum. The fat isn't completely normal, and if you look back here, azygous vein, there's some tissue in the area of the thoracic duct, so it looks like a dilated thoracic duct. So they did a transbronchial biopsy as well. It showed a lipoproteinaceous fluid, nothing consistent with alveolar proteinosis. So our working diagnosis in this guy is pulmonary lymphangiectasia, which can cause like a plastic bronchitis, but he's not forming CAS, but rather his is more liquid materials. He actually feels a lot better following his bronchoscopy and clearing some of the stuff out, which correlates with his CT scan from this morning, which showed that we're sort of back where we were in mid-June. He looks kind of like this now. So our thought is this is a pulmonary lymphangiectasia. So I think the next step for him is getting a lymph angiogram to see if there's a particular area, and maybe even coil him. One of our interventionalists has done quite a few of these and is very familiar with the literature on this. But I don't know if you guys think differently, but that's probably our best guess at this point.
And you think those septa are because the septal lymphatics are large?
Right.
Is lymph in the septal lymphatics, perhaps?
That's
part of,
which would explain the perilymphatic distribution of this abnormality, the sort of the subpleural little outpouchings here and thickening along the fissure. You know, it's interesting because we were going back and forth over this with emails and whatnot, and there's some confusion in the literature. There's another entity called lymph angiomatosis, and a related syndrome called Gorham-Stout syndrome, where you get bone involvement. But that seems to be a different process. Those cases, and I know I have one from David and one from Seth, where there's sort of diffuse infiltration of the mediastinum and more perihilar disease. So I think there's some confusion in the literature out there, but I think this is lymphangiectasia. I've seen it in children before. It's well described in the review articles on pediatric interstitial lung diseases. There's a lot on it, but it's mostly just case reports. And then there was one paper that Tom Colby co-authored that talked about this as well. So, you know, before there wasn't a lot of treatment, but apparently some of these there's some monoclonal antibody that may show benefit. And then also some of these may respond to, there's some expression of VEGF-D, so they may respond to a sirolimus or something.
And there were no bone findings to go with Gorham's or anything?
Not in this patient, no. And interesting, the one with Gorham-Stout syndrome have a better prognosis if the bones are involved than if it's just isolated to the lung. So it must be a different mutation or something. But, you know, this was a previously healthy guy. He works in a factory, but didn't really have any direct exposures. But very fascinating case.
So this is different than congenital lymphangiomatosis,
Correct.
Which is interesting.
My understanding of it, that lymphangiomatosis is proliferation of lymphatic channels. Sort of you get multiple lymphatic malformations all throughout, whereas this is just sort of dilation of the pre-existing lymphatics.
I have a case I can show next week, a second case of lymphangiomatosis that I drenched up from, had scanned from the film days. It looks like it looks a lot like the case that I've shown before that you have in your teaching file now.
So Jeff, in this case, the material that ends up in the alveoli, is it lymph fluid? And then how does it get there and from where exactly? Is that understood?
Well, there must be some outflow obstruction, and it probably weeps in through the normal channels and accumulates there because it's a low pressure, negative pressure area, and I think it just pools in there in the lung lymphatics. But I think that's the value of the lymph angiogram, because if you can show the lapiodol sort of spilling into the airways, it sort of confirms the diagnosis without having to do a wedge. And you know, our pathologist was debating whether a wedge would really be that helpful in this case, since it seems to be pointing at that. It'd be easier to do a lymph angiogram, and it may be therapeutic as well, whether it's from sclerosis or from the thiodol itself, or even coil embolization of the thoracic duct. We've been very successful doing them percutaneously here, so I think that's our plan. So I'll send, when I get more information, I'll pass it along, but I think that's what we're going to go with this. It's just a fascinating.
So, Jeff, how old is this guy, and how long has this been going on?
So he's about in his early 30s. He presented in February with a cough, and so he was called pneumonia based on that CT somewhere else, and eventually was referred up to our center.
And you said he had IgM or IgG deficiency.
He also has IgG deficiency, and that's how everyone got focused on alveolar proteinosis. There is an association apparently, but it just doesn't. And then we tried to see if there was some timing with the imaging findings and the IgG infusions, but that first CT I showed predated his IgG deficiency something. So maybe he's spilling IgG into his lymphs, and that's why he's deficient. Well, I don't know. We'll find out, but I thought it was perfect timing because of your case. So, okay, well, let me show this other case because I got confirmation on this one. So this was a a young person who came to our emergency department with hemoptysis, and you can see there's this cavitary-like lesion in the left lower lobe.
I'm still seeing other case, Jim.
Well, that's
the old case.
How is that possible? I don't even have it loaded. Okay, there we go. Well, here it is. You see it's on the left lower lobe, and here's a backwards radiograph, Röntgengram, but there's this mass-like area in the lower lobe with cavitation. So here's the CT scan, which shows two different findings. First, it shows this ground glass opacity, predominantly in that right upper lobe, creeping into the middle lobe as well. Looks very, what's the word I'm looking for? Acinar type. And then here's this ugly, ugly cavity in the left lower lobe, and then sort of this background ground glass. So obviously infection, tumor, but it was a relatively younger patient. So with the hemoptysis, you'd have to consider vasculitis with some hemorrhage. And I'll show the soft tissue.
And no vessel going to that cavity in the left base.
Well, really, there's some vessels in the wall of it, but normal-looking vessels, nothing that looks like a pseudoaneurysm. So
I think David is asking aorta feeder. Is that what you were thinking, like a sequestration?
Yeah, sequestration, yeah.
Systemic arterial supply, correct. Yes, good point, David. So anyway, this patient also had some renal issues, abnormal urinalysis. So they did a biopsy of the kidney, and it showed a necrotizing granulomatous crescentic nephritis. And then further digging through notes or subsequent notes documented many years of sinus problems. So, so working diagnosis of GPA. So anti-proteinase 3 was positive, so that's further supportive. And with the kidney biopsy and all the lung findings, this is a case of GPA. Presenting as hemoptysis, but probably in retrospect had sinus disease for some time.
Cool.
Alrighty, and then one last interesting case, and I don't have a final diagnosis on it, but and I'm going to make sure you're actually seeing the right images. So this is a young woman who carried a diagnosis of myasthenia gravis proven by autoantibody. Had a thymectomy many years ago. I don't have her original imaging, but never had a thymoma, just had thymic hyperplasia, and was presenting still with some weakness. And so this CT was done to look for recurrent thymoma, or to look for thymoma following surgery. And you see there is some residual thymic tissue here, but we didn't see a mass. But what was quite striking to us was this marked atrophy, fatty sort of metaplasia of a lot of her muscles. You look at this pectoralis muscle on both sides, and even the sort of the deltoids are kind of getting a little bit thin. And then as you went down, her latissimus dorsi and her paraspinal muscles are very atrophied. Yet other muscles, serratus, is relatively preserved, and it's very symmetric. So it doesn't look like a denervation type picture. So, I'm not familiar with myasthenia causing atrophy, and I did a little digging, and she had seen a rheumatologist one time but never followed up. But they had subsequently, after the CT, sent off some autoantibodies, and these anti-RNP and SM Smith were positive. So it might fit with a mixed connective tissue disease, but I'm wondering if there's a myositis mixed in here. And the neurologist noted some mild weakness. I'm surprised it's not more in the proximal limb, so the proximal legs, which I don't have imaging of, as well as the shoulders. So I'm wondering, and then of course the real reason I saved this case is the beautiful NSIP pattern on her lungs, as well as her abnormal esophagus. So I'm wondering if she's a mixed connective tissue disease or some sort of overlap with some myositis, maybe not a scleroderma type picture, but maybe something without the skin findings that unrelated to her myasthenia. Have any of you ever seen myasthenia gravis cause marked muscle atrophy?
Not like this. This looks like polymyositis. No.
That's what I think. I think she's got an overlap, and she just has a history of autoimmunity and just happens to be another one. But they didn't send off the myositis panel yet, so she's supposed to see a rheumatologist, but I can't imagine it's going to be anything but. And there's not an
So Jeff, do you think this could be, you don't think this is a paraneoplastic kind of polymyositis related to, maybe there was really a kind of thymoma there, or some other neoplasm I'm not aware of myasthenia associated with polymyositis by itself, but I just wonder if there's a thymic tumor sort of
I'm just
lurking
wondering
behind.
if she's predisposed to autoimmunity, and she never had a thymoma. She had a thymectomy. She has a residual thymic tumor. I mean, it can be associated with Hashimoto's, the myasthenia, sort of autoimmune thyroiditis. So, I suspect it's just yet another autoimmune prone person that happened to get us something else. But it's sort of a mix. It has some features of myositis, some features of maybe not quite scleroderma. She doesn't have the skin findings, but sometimes those telangiectasias at the nail beds are very subtle, and they're picked up by a rheumatologist with more experience. So I don't know. I'm also on my list to follow up, but I think it's a really fascinating case of myositis, which was not really being entertained by neurology at the time. They were more focused on it just all being myasthenia causing her weakness.
I guess the other thing I would bring up is what is that syndrome of? It's an autoimmune syndrome associated with cancers that causes a profound weakness. Sometimes people can't even get out of bed. It's got two people's names on it. I can't remember.
Yeah, I know what you're talking about. But as far as I know, she has no malignancy. It's there's nothing pointing to a malignancy. She's not losing weight, not having
Eaton-Lambert syndrome.
Lambert-Eaton.
That's the one.
Yeah.
Thank you, Doctor.
Yeah.
Right, Ellie. I mean, there's a great Netter drawing of a guy with it too. He's got I think he has a small cell cancer, and he shows him with a COPD phenotype and sort of a blue bloater, and he's got small cell, and he's got all these paraneoplastic syndromes and clubbing. I vaguely remember that from medical school.
I think the Eaton-Lambert, though, can sometimes precede the diagnosis of malignancy. Sometimes that can be presentation of malignancy. Right. So
she's young. It would be unusual. I don't know. It's possible. It's just unusual. And I think it's most commonly associated with small cell cancer, the Lambert-Eaton syndrome or Eaton-Lambert, whichever order you like. Yeah. And the other thing is, though, it's interesting. Her myasthenia had gotten better after her thymectomy, but I think there was some residual nest of thymic tissue because we can see them on CT, and that would explain some of her symptoms. But it sounds like this is a separate process, but it's hard to tell. I have very limited clinical notes because she was a new referral to neurology here from somewhere else, and I have no records of her thymic surgery. They did document from many years ago a myasthenia autoantibody. So. All right, well, we'll stop here. Thanks, everyone. Great cases, as always. And so we'll continue next week, and we will skip Thanksgiving week, obviously. And we can touch base about RSNA week. I'll be here. So if you got even if 2 or 3 people around, I think we'll do it RSNA week.
Sounds good. Thank you.
All right.
Thank you.
Bye, everyone.
Thank you. Bye.